sir. My topic is on RAS protocol in hip arthroplasty, sir. The Enhanced Recovery After Surgery Protocol is a comprehensive therapeutic approach that prioritizes the well-being of patients. It aims to optimize preoperative preparation for surgery, minimize stress response to surgery, PD recovery and return to normal function, early recognition of abnormal recovery, and intervention if necessary. ERAS protocol can be categorized into three distinct components: preoperative, intraoperative, and postoperative phase. Most of the patients presenting with hip fractures are elderly. Physiological changes and associated comorbidities should be taken into concern. Once the diagnosis is radiologically confirmed and the patient is deemed to be operable, enhanced recovery program initiated. The analgesia begins in the emergency department and includes an ultrasound-guided single injection fascia ilia block by either an EMD physician or an anesthesiologist trained in pain medicine. The anesthetic goals in ERAS is to minimize stress response to surgery, provide optimal operative condition, to select appropriate surgical approach, multimodal opioid sparing analgesia, restrictive perioperative fluid therapy, maintenance of normotherapy, avoidance of nasogastric tubes, rapid recovery of physical functions via early ambulation and early oral intake, post-op nausea and vomiting prophylaxis, avoidance and early removal of drains and catheter. Coming to preoperative phase. Preoperative optimization of patient comorbidities with special attention to diabetic and blood sugar control, anemia, malnutrition, bone health, and other medical problems. Smoking cessation and advice on alcohol consumption will help to reduce postoperative complications. Rehabilitation and counseling for post-op patient participation. Reducing fasting interval prior to surgery, that is 2 hours for clear liquids and 6 hours for solids. Delirium prophylaxis, thromboprophylaxis, uh, multimodal opioid sparing analgesia, including paracetamol, NSAIDs, and we can repeat fascia iliac block if the last block is greater than 80, given as greater than 18 hours. Coming to intraoperative phase, standard ASA monitoring attachment, securing the peripheral IV line, better to avoid central venous line. And in this case, neuraxial anesthesia is prioritized as the initial choice for patient undergoing hip arthroplasty. If general anesthesia, total intravenous anesthesia with short-acting opioids and muscle relaxants to be preferred. And we can also put local infiltration analgesia or motor sparing nerve block like pericapsular nerve block and fascia iliac block. It is the most essential pain treatment remedy across the periop period. And infection control with antibiotic prophylaxis 1 hour prior to incision, and then prevention of intra blood loss by administration of tranexamic acid, and cell saver can be used if there is major blood loss, and then maintaining normothermia using air warming devices, reflecting blankets, and warmed infusion of fluids, and then goal directed fluid therapy to maintain euvolemia and normotension. Post-op nausea and vomiting prophylaxis, dexamethasone 0.1 mg per kg up to 10 mg can be used, and ondansetron 4 mg at the end of the procedure. Arpipretin and scopolamine patch can also be used. And then multimodal pain management involving paracetamol, NSAIDs, minimal short-acting opioids, fentanyl can be used. And then avoidance of tubes, drains, and lines. Next, post-operative phase, it involves early reception of oral intake, maintenance of hydration by encouraging oral intake, including the carbohydrate drink, and the discontinuation of IV fluid therapy. Any drains, urinary catheter, and lines are removed as early as possible. Early mobilization improves the quality of surgical care. And then involvement of physiotherapy and rehabilitation department is vital to help with patient motivation and safety. Multimodal analgesia for pain relief, again including NSAIDs, acetaminophen, minimal short-acting opioid, and again to repeat fascia iliac block if time is elapsed. In summary, enhanced recovery after surgery provides evidence-based protocol to minimize surgical stress response, post-op pain, expedited recovery following elective procedures, and decrease the length of stay in the hospital. That's all, sir.
Okay. Now, discussing this topic of ERAS protocol, who introduced this ERAS protocol into practice?
Sir, Henry Cleith,
In brief, is it a surgeon or an anesthesiologist? And for which surgery they introduced this, which has now slowly got transformed into all the fields of surgery.
For colorectal procedures.
Very good. Dr. Kellett. His
Kellett,
name is a
yes.
Swedish surgeon. He was a Swedish
Yes,
surgeon, and he wanted to minimize the hospital stay by evaluating the patient preoperatively. Almost you can compare it with the daycare procedure, where you evaluate the patient as an outpatient in the preoperative phase, do all the necessary investigations, and optimize the patient preoperatively, whatever deficiencies are there, control the comorbidities, and then do not starve the patient too much, which is a very important aspect of VIRA's protocol, because he found that keeping the gastrointestinal tract dry without food or liquids for a long time leads to post-operative VH and other complications. And also psychologically, patient feels better if you allow them to drink water, plain water, even up to 2 hours of surgery without too much of restriction. So all these things, we found that it helped in the faster recovery of the patient. And not many tubes in the patient, like nasogastric tube, urinary catheter, or wound drainage. All these things were very, very minimized unless it is absolutely essential. And resumption of oral intake in the post-operative period as early as possible. Contrary to the belief in the earlier period that 24 hours or 36 hours of meal by mouth was absolutely essential. So all those things were modified by him in this VIRA's protocol. And it was for an elective colorectal surgery, mainly for colonic cancer patients. But in the case of hip arthroplasty, your discussion now focuses mainly on elective hip arthroplasty, isn't it? What you
yes,
have
sir.
now talked about is about elective hip arthroplasty. But hip arthroplasty will be done majority of the times in which category of patients? Is it done in the very young age patients, or is it in the elderly patients?
Elderly groups.
Elderly patients. And is it done as an acute procedure for fracture, or is it done as an elective procedure all the time for osteoarthritis or joint problems?
It is an acute procedure only, sir.
You come across this procedure mainly in the elderly who suffer a fracture as an acute condition, isn't it?
Yes, sir.
So the discussion of this topic in hip arthroplasty should focus mostly on acute fractures which come for hip arthroplasty in the elderly individual, rather than treating this question as an elective procedure for a non-fracture hip pathologies, like you say osteoarthritis or rheumatoid arthritis or other joint problems. So if you think it is an acute presentation with a fracture, what are the challenges in this patient? You mentioned about on-arrival block or the fascial block. You have mentioned
Yes,
about
sir.
fracture also there.
Analgesia. Yes, sir.
So how soon a patient with a fractured neck of femur, an elderly patient, should be operated?
24 hours to 48 hours, sir.
With 24 hours. Why they have earlier they were taking long time to optimize the patient, identify the comorbidities and all those things, and then trying to correct it and take it up even after 3 days, 4 days, 5 days. What happens when you wait for a prolonged period of time in an elderly patient with a fracture?
Sir, chances of venous embolism, sir.
DVT, okay, okay.
DVT.
Deep vein thrombosis, because the patient becomes bedridden. Deep vein thrombosis is one problem. They cannot move the limb, especially if it is very painful. Very good.
Yes,
Then
pressure sores, sir.
Pressure
feeling
sore,
prolonged.
excellent. Within second or third day, if you don't take care of the patient properly, they will develop pressure sores in the pressure points, especially in the sacral and lumbar regions where the pressure will be maximized. And that will be a hindrance to your regional technique like central neuraxial blockade. Very good. What are the other things?
Blood loss,
Blood loss after the fracture, will the
bleeding.
patient be going on having bleeding?
No, sir.
Blood loss will happen immediately after the fracture and it will be collected in
Yes,
that
sir.
capsule and
Area, yes,
hip
sir.
area.
In
But he will not be going
infections,
on infection. Okay.
infections.
Infection is one. What about the electrolyte and fluid balance?
Yes, sir. Electrolyte imbalance,
They will
nutrition.
not be taking food or fluids properly because of the pain. Unless the pain is
Yes, sir.
properly managed, they will not be taking any oral intake properly. So they may get dehydrated. They go in for electrolyte imbalance. Okay.
Imbalance.
And
Yes, sir.
elderly people, what is the central nervous system effect if they are persistently
Delirium,
suffering from the cognitive dysfunction. The
cognitive
word
dysfunction.
cognitive dysfunction will be a better terminology than calling it as a delirium.
Delirium.
Okay?
Yes,
So
sir.
these are the things that will be happening if the patient is made to wait too long for optimizing the comorbid conditions. And to avoid these complications of waiting, the, the concept of enhanced recovery was introduced for hip arthroplasty. Okay? So
Yes, sir.
the main point that you have to include in your otherwise well-prepared answer is the timing of surgery and the nature of the patients. Okay? Because they are all
Okay,
mostly
sir.
elderly, they have a lot of comorbidities. And in your question, in your answer, your mode of pain management, there are a lot of repetitions because you have divided it into pre-op, intra-op, and post-op.
Yes,
You
sir.
are made to repeat the opioid-free anesthesia or analgesia again and again in the pre-op, intra-op, and post-op. So all that has to be trimmed and pruned a little bit. And the presentations should be made a little bit more
Okay, sir.
non-repetitive so that you have time to finish the answer in your examination. Okay.
Okay, sir.
Otherwise, you have